I want to welcome you all to this presentation from Progressives Against Medical Assisted Suicide. These are very important issues, and for many people difficult questions to consider. The featured speakers are Anita Cameron, Director for Minority Outreach at Not Dead Yet, a national grassroots disability rights organization that opposes legalization of assisted suicide and euthanasia, and Dr. Andre N. Sofer, Professor of Medicine at the Yale University School of Medicine. Progressives Against Medical Assisted Suicide is composed of peace, justice, and disability rights activists, advocates for single-payer health care, and supporters of women's reproductive rights. We confirmed this date 6 weeks ago with Anita to join us here, and since then, October 2nd was picked as the date for the Women's March, which is being held in cities all across the country. We were not able to reschedule the event, but I want to make it clear that we all stand in solidarity with the many people who are marching for women's rights today. We're very relieved that the bill in the last legislative session to allow medical assisted suicide did not pass. There is great danger, especially for people with disabilities, people of color, the elderly, and people without financial means, of being coerced into agreeing to medical assisted suicide. Coerced by the medical system, the insurance industry, and unfortunately, family members. And ethically, the role of doctors should not be to help people kill themselves. After our speakers, there will be time for questions and answers, and people are welcome to give their own comments of experiences they've had. We have 2 videographers today, and if anyone wants to speak without the video on and to speak only to those here, please let us know. Our videographers will shut off their cameras, and you will only be addressing those of us in the room. So thank you very much, and I now will yield the microphone to Elaine Kolb.
For many of us, the issue we are discussing today is profoundly personal and, in terms of political and social realities, absolutely terrifying. Speaking from my heart and soul, it is such a joyful thing, an honor and privilege to be introducing my dear, dear friend, comrade, in the trenches together, been arrested together many, many times, Anita Cameron. We go back, way back. My first connection with ADAPT was back in 1987. And over the years, we've been all over this country and even into Canada, and we've been arrested. Now, I tell people I've been arrested 27 times, and most people think that's quite a lot. Anita's been arrested 137 times? 139 times, hello? And I can testify from having been there in person that yes, indeed, there is a factual obvious, clear fact that people who are black or otherwise not white get extra special treatment almost everywhere when it comes to arrest and incarceration. And I've observed this, and yet Anita keeps doing it. I want you to know that some of you here kind of know me, and others are getting to know me, and some, it's brand new. One of the reasons I'm still here and still doing what I'm doing is because of Anita Cameron. Her example and her support when it's gotten tough. I don't want to really do justice and tell all this stuff about Anita. It would take all the time we have. I don't want to do that. And yes, if you could turn off your different instruments, that would be helpful. I know we're in the modern era, and that's how it goes. But anyway, I was just so thrilled when we were able to make the arrangements, and I was so relieved when Anita's multiple complicated medical situations and conditions stabilized enough for her to get on that bus and ride all the way here to be with us. You're in for a treat. It is my deep, deep honor to introduce Anita Cameron, and she and I are bonded with the determination and the principle, we're gonna stay on the battlefield. I'm gonna stay on the battlefield. We're gonna stay on the battlefield till we die. But we're not dead yet. Anita Cameron, you're in for a treat.
Okay. All right. Good afternoon, everybody. Woohoo! Wait a minute, come on now. I understand, it's a little, but good afternoon, everybody.
Yes!
I'm Anita Cameron. I am Director of Minority Outreach for Not Dead Yet. It is an honor to be here. I hadn't done any traveling for work or this important related issue since COVID, and so I'm really happy and actually honored that, with my health stabilizing just a tiny bit, and all that, I can be here and talk to y'all. I think what I'm gonna do is just tell y'all about myself, and how I got into this and what this means to me. So I was born in June of 1965. Y'all do the math. In Chicago, Illinois, and I was born too late to participate in the civil rights movement, and other things. And so as a kid, I felt guilty about that, because I learned to read at a very early age. I was raised in an area, I grew up on the street that had the Black Panthers breakfast program, children's breakfast program. I grew up in that Black is beautiful, Black and proud era. But I was just a kid, and I was like, oh man, I didn't get to do stuff to help folks. So as a small child, being very idealistic, shall we say, I decided that when I died as an old lady, that I want to make this world a better place for everybody. That by the time I left, the world would just be a little teeny weeny bit of a better place because I existed. At the age of 16, I got involved. I was a good little Catholic girl growing up, and I got involved with the nuns who taught me about social justice and social change. And from there, I got involved in all kinds of movements: the anti-nuclear movement, anti-apartheid, women's issues of homeless people, LGBTQ, issues, and then finally, I found, or maybe it found me, this group called ADAPT, and it was a disability rights group, and I joined in 1986. Did local stuff, and a couple of years later, wound up in Colorado and wound up going to national actions and doing all kinds of stuff. And it felt like home to me because, for one, I wasn't the only disabled person. There are all kinds of disabled people, and I wasn't the only black person. So there was people that looked like me and came from the similar backgrounds and whatnot to do this important work. In 1996, one of my friends in ADAPT, Diane Coleman, started a group called Not Dead Yet. And it was in the context of it, at that time, Dr. Jack Kevorkian was doing his horrid things, helping people to die. The study showed that most of those people, who were women anyway, were not terminal. Some were not even disabled. And so Diane started Not Dead Yet, along with a couple of other folks in ADAPT. And to me, it was a natural outgrowth of the disability rights movement. Sorry, keep my mask slipping off. And so, of course, I was like, yeah, this is important, But then, a few years later, back in 2009, I'm living here in New York, in Rochester. My mom is out west in Washington State. Washington State had just enacted its assisted suicide laws. And I got a call from a frantic doctor saying, if you want to see your mother alive, you better get to Washington State in 2 days. She's just that sick. My mom was born with chronic obstructive pulmonary disease, and the doctor said that she was at the end stages of it. So, of course, me loving my mom the way I do, I hopped on the next thing smoking out of Rochester and got myself to Seattle, Washington. And my mom rallied, because I called her up and said, I hear you're sick. Mom, you want some company? And she was like, yeah. So, she rallied, and I stayed, for a few days. But she was sick, and they did put her in hospice. And they put her, on all these meds, and the doctor said, hey, her body's beginning the process of dying. My mom was the first person I had ever known in life to be in hospice for 6 months. Usually, when they say hospice, it was a matter of days or hours. And here my mom, she graduated hospice. But her doctor had still convinced her that she was dying, that her body is beginning the process of dying. That was a mantra we heard over and over. And so after my mom got out of hospice, she was convinced that she was dying, so we made the arrangements. I from New York and, on her end to go to Colorado. Colorado was her home. And she wanted to go back to Colorado to die. So we made the arrangements, and we got her an apartment and got her attendants, nurses, home health care, and moved my mom into her apartment. And she went waiting to die. 6 weeks later, my mom hadn't yet died, of course. And then we were in Washington, D.C. with ADAPT. And there my mom was on her bucket list. It was on her bucket list to go on the National ADAPT Action. Okay? So she had wanted to do some things before she died. And she had been on local actions with me and gotten arrested with me. But she figured before I die, I want to go on one of these ADAPT things. And so she was in Washington, D.C. getting arrested. Fighting for disability justice. I mean, oh my goodness. Yeah. And so months passed, years passed. My mom did not die. And after a while, she just got to the point where, she's like, I'm too ornery to die. I'm going to go on and do my thing. So she became active in her community. As much as I could, I'd get to Colorado and see her and chill with her, and everything. And she wound up going on another National ADAPT Action and getting arrested. And we had my mom for almost 12 years. She passed away on February the 1st of 2021, this year. And it was interesting. It was really, I think about my mom and I feel her here today because our last conversation, we talked about this issue and how important it was, to me, and how she had actually, because of the work that I had done, had really, her stance on this and everything, her horizons were broadened, if you will. And the last words we said to each other was, I love you. And I'm really, yeah. But, as my health got more and more complex, this issue became personal for me. Because the proponents, they say, and that's why I tell my mom's story all the time, because the proponents say, no, this is only for people who have 6 months or less to live. If my mom, as I said, Washington State had just enacted their assisted suicide law. My mom was deemed to be terminal. All she had to do was ask. And they would have given her the medication because she was deemed to be terminal. And what's even more scary for me is that my mom and I are close and we loved each other very much. And I've seen my mom go through some terrible health issues. And she trusted me, and all I would have had to have done was to say, Mom, it's okay. Why don't you, take this. And she would have done it. And thank goodness, I just thought in my mind, fight. And my mom, too ornery to die, she finally, realized that. So, and her story isn't the only one that I've heard about people deemed to be terminal. There's a story of a woman, Jeanette, who had cancer in 2001. She wanted assisted suicide. Her doctor urged her not to give up. And she says, I'm so thankful, she's alive 20 years later. And she said, I'm so thankful that my doctor encouraged me, that had I got what I asked for, I wouldn't be here. And so, but as my health became more and more complex, my health needs, and I've given testimony around the nation, in person and remotely, against various states' assisted suicide bills. And I got the opportunity to speak to y'all legislative, African American, Puerto Rican caucus, legislative caucus. I got to speak to them. And so I'm happy, I'm ecstatic that y'all bill failed.
Yes,
I'm so excited. But, people talk, when I hear the proponents talk, and trust me, I'm a compassionate person. I got a heart, but they all, their commonality is that someone had a bad death. Someone went through pain and suffering and all of that. And I have a number of conditions. 2 of them are degenerative. One's eventually going to take my life, but and I live in pain, abject pain. I don't talk about it much because when you're in chronic pain, you learn to deal with pain differently than others. You learn to handle it, differently. You learn to hide it, and so I hear this, but then, in my adventures, if you will, and my testimonies and all of that, I hear these people, even more than the pain, they talk about a loss of dignity. See, the thing about it is that, these assisted suicide laws are horrific anyway, and they set it up so you don't really have to do any studies or reports or anything. But Oregon, which is the state that's been doing this 23 years, so it's the longest state, they put out a study of why people ask for assisted suicide. And they put out the study periodically, and they had one in 2018. They just did one, released one a couple of months back. And the top 5 reasons people ask for assisted suicide, the number 1 is a loss of autonomy. These are people who have been either deemed terminal, or they're afraid they're going to be terminal, or whatever, and so it's a loss of autonomy for them because of their condition. Feelings of being a burden, a financial, emotional, physical burden. The loss of the ability to do things that you enjoyed, the loss of the ability to do that. The loss of control of bodily functions, such as incontinence, vomiting, and feelings that they're going to be a financial burden on their family. Pain doesn't even come in the top 5. It's down to 6 or 7, and as a matter of fact, they in 2018, they kind of changed the rules a bit, and they said pain or the fear of. And that only brought it up to number 6. So what people are afraid of, why they want the suicide drugs, are all reasons having to do with disability. Existential fears related to disability that can be dealt with by having services and supports in your home, you know, you getting the care that you need. Thing about it is that everyone who's sick or terminal or whatnot also fall under disabled. So all those folks that are, disability is a subset, but by that time, you're falling definitely under the Americans with Disabilities Act definition of what a person with disability is. And that's what that is. And I can't tell you how many times, and I've heard it from mostly, well, how can I be delicate about this? Or maybe I shouldn't. The people that are wanting this are largely folks of higher socioeconomic status, people who are upper middle class, professional class folks, and largely white. They are the folks who are wanting this, who are wanting assisted suicide. That's just a fact. When I was growing up, and I grew up in like I said, black neighborhood, black experience. I'm Afro-Latina, and so my dad he was from Cuba, came here in 1945, and so I heard of people getting depressed, but you know, in the black community, we don't talk, you know, that suicide is not, certainly wasn't back then as prevalent, and the thought of having someone assist you in that, or having someone, you know, that was, oh my God, that thought never came up. And as I learned more about this, especially after Not Dead, Joan and Not Dead Yet, I just figured, I don't know, this is some privileged white folk thing, that people want to, you know, not only take their own lives, but have the government, you know, assist you in this. Because, you know, to me, I mean, assisted suicide laws are deadly because they put large swathes of the community in danger. Another, shall I say, delicate subject, racial disparities in healthcare. And they are out there, and there are many, many studies that show racial disparities in healthcare. Studies show, certainly for black folks, the care is inferior in the areas of cardiac care, diabetes, cancer, pain management. I have diabetes and pain management issues going on. Another thing that they don't tell you, and it's hidden in these laws, people say terminal, but terminal by what? Because, and all these, we talk a lot about Oregon, because these states that put forth these assisted suicide laws, they're all based on Oregon's law. It is the standard. And so with very few exceptions, the laws are based on Oregon's law. There was a gentleman named Fabian Stahl from Sweden. Sweden was considering adopting its own assisted suicide laws. And so they'd heard of Oregon, and they had some questions. Mr. Stahl had some questions for the folks in Oregon. And one of the questions that he had was the meaning of terminal and what can make you terminal. So one of the questions he asked, and he used diabetes as the example, He said, if someone loses access to their medications, to their insulin, if they're diabetic, and they lose access to it, can they then apply for assisted suicide under Oregon law? And the Oregon Division of Health said, yes, they can. They further said, the law is intended to be inclusive, not exclusive, and it didn't matter what made you terminal. So if you decided, look, I can't take this treatment no more, I can't deal no more, it's too much for me. If you decided not to deal with your disability anymore and you just wanted to die and you lived in a state where that was, and Oregon says yes. That is frightening.
Yes.
I met a lady named Stephanie Packard. She was, when I first heard her story, she was in California. But she's now in Maryland. I believe she's at Johns Hopkins now. But she had a condition called scleroderma. And she was getting treatments for that. And her treatments were costing the state of California, and her insurance company rather, the treatments were costing about $3,000 a month. And she had just gotten approved for her treatment, but a few days later, the state of California enacted their assisted suicide law. And so a couple of days later, her insurance company wrote her back to say, well, Ms. Packard, I'm sorry. We've determined that, this just isn't helping you, and here's some other options on the table. And one of those options was to take the suicide drugs. And Stephanie Packard asked them, look, out of curiosity, how much does the suicide drugs cost? We already know my treatment costs $3,000 a month. How much does the suicide drugs cost? What's my copay? Her copay was $120. So it's easier to kill you than to give you health care. And that was the consequence nobody thought of when they thought of these laws. Because she wasn't the only one. A guy named Randy Stroop out of Oregon went through the same thing. Several folks got letters from their insurance company saying, we've determined that this course of treatment is not helping you. Here's some other things on the table. And in every case, the assisted suicide pills was on the table. And think about if you're poor, and you're going through treatment, whether it's for cancer, whether it's from your condition, and you don't want to put your family in. And that's what's going to end up as things go on, as this is normalized. That's what's going to end up happening. Is it's going to come down to your insurance company coercing you into taking, or you feeling that I don't want to be a burden. Or you got unscrupulous family members out there. Unfortunately, they exist. Or you have, the situations of racial disparities in healthcare. Think about if you are not getting your pain meds, your pain isn't being treated properly, and you live in a state that has assisted suicide. That's what I was so worried about here lately with my mom. She was living in Colorado, unfortunately, because it went on the ballot, adopted an assisted suicide law. And my mom needed knee replacement surgeries and a couple of other surgeries. And but because of other health issues, that would present some problems. So you'd have thought that they'd have given my mom adequate pain treatment, but they kind of weren't. And so I was worried about that. But people who worry about pain. I've already made my decisions and preparations. When the pain gets to be that much, that's what palliative care is for. And a lot of people think palliative care is for people who are dying. It's not. It's treatment of your pain. And then, there is palliative sedation. If it gets, that bad. It is extremely, extremely, extremely rare that pain isn't controlled, that pain can't be controlled. And so these folks who are worried about pain, that's what palliative care is for. Push for that. And we really need to have more access to that, access to hospice care, access to care in your own home. Because if your choice is little poor help or winding up in an institution, and that happens a lot to us, something called the institutional bias. And what that is if you're disabled, in particular, nursing home care, institutional care is mandated by the U.S. government, but care in your home is not. It is what's called an optional service, and that's what we have been doing in ADAPT for decades, is fighting for people with disabilities to have the access to and the right to receive care in their own homes or in the community, and not, be forced into institutions. And as we are to this very day, if states go through budget crises and whatnot, first thing that goes are the optional services, and that means a lot of people with disabilities get their services yanked. But nursing homes, they get their yearly allotments, or they may even get raises. And so that's what the bias is. And one of the things that groups like, that ADAPT in particular is working for is to end that institutional bias. That if we have, a guaranteed, way that people with disabilities, that we can get our attendant services, that we can get the things that we need to live independently in the community and to give our gifts, to everyone, and to be gifts to everyone. That's what we need. But unfortunately, we have this attitude about disability that is dangerous. And another reason why these assisted suicide laws get normalized, because there are movies out there, You Before Me, a few other movies that romanticize this. It's almost like it's better to be dead than disabled. No matter how complex your disability is or how quote-unquote severe it is, you can have a good life with the services and supports that you need. I've seen it all over this country. I've seen it for the 35 years that I've been involved in disability rights, disability justice movement. We have amazing gifts, and unfortunately, there are doctors who feel that we, as people with disabilities, have a lesser quality of life, and that leads to disability discrimination. It leads to the undervaluing or even devaluing of the lives of people with disabilities. And so there, some doctors and disability discrimination and all. I always say, as long as we have disability discrimination in medicine and racial disparities in healthcare, there is no place for assisted suicide laws. There is no place for assisted suicide. And unfortunately, in states that have it, there are states that are wanting expansions to their laws that they already have. So, I believe it was, there's states that want expansions for people with mental health disabilities. Now, what does that do? We've all heard of suicide prevention. What does that do to suicide prevention? That just turns it right on its head, these assisted suicide laws. Because if you, and I'm sure on the flyer that you saw, the cartoon that Amy Hasbrook out of Not Dead Yet in Canada did this one where people with disabilities, we are totally different. So you have people with communication disabilities. And so the therapist or the psychiatrist can't deal, because they don't teach you about disabilities or people with disabilities in med school. They don't teach you about that culture. They teach you disability is something that needs to be fixed, and these poor people or whatever. And so oftentimes it's a struggle for people with disabilities to get mental health treatment. And because if you're disabled, if you're relatively young and you're non-disabled, you're not sick, and you express desire to end your life, you're going to get help or treatment whether you want it or not. And if you're disabled, they say, oh, I can see why you're depressed. You're disabled. I'm gonna end, but I'm gonna tell you, this happened in 2019. Shortly before the National Council on Disability put out a position paper on a number of issues, assisted suicide being one of them. They put out a paper on why assisted suicide is dangerous public policy. If you want to Google that, ncd.org, assisted suicide, Google that and it'll come up. And there's some of my work is stated, there are references to some of my work in that. But there was a young woman, 24 years old, who contacted a friend of mine to say goodbye. The reason that she was saying goodbye was she had just graduated from hospice. She was another who had been in hospice, but she had been determined to be terminal, but had survived her hospice. And she really thought she was going to die. She had her family come from all over the country and the world to say goodbye, but she didn't die. But she was tired of being disabled. She was one of those young women who had done some beautiful things in her life as a person with disabilities. But she was tired of being disabled. And so she got a hold of the suicide drugs, and she was saying goodbye to her friends. And her friend contacted me, and I got a hold of Diane, Not Dead Yet, and we're like, look, what's going on? Are there things that you need? Are there services that you need? I finally asked her a question. I said, did you talk to your therapist? What does your therapist think? Do you have a therapist? Did you talk to her? And she said, well, I talked to my therapist, and my therapist said that it was okay, that it was totally understandable that I would be sick and tired of being disabled, and I had the right to die. And with that, she took the medication, and the next day it was confirmed on her Facebook page that she died. And then a couple of her relatives contacted me, not exactly happy, but to also verify that she died. And I thought, oh my goodness, that was just horrible. If she were not disabled, that therapist would have been all over her to help her live. But because she wasn't, because she was disabled, and that's the thing, they want to rationalize why it's okay to be depressed. And I will tell you that there's a couple of states out there that require you to get a mental health assessment. But the assessment is not for any disability, depression, or whatever. The assessment is that you're able to make the decision that you are. It's to make sure that you it's to make sure that you aren't, that you're thinking okay, that, and so it's not even that, and it's like 15 minutes. What can you learn about someone in 15 minutes? What can you can't. So, this is for me, until I draw my last breath, I'm going to fight against this, because there's so many of us, marginalized people who are in danger of this. And so, as I just said, adapt, I kind of feel a song coming on. And in my life, I fight for freedom. And so I'm just gonna
go for it.
Can I?
Go for it, honey. Go for it.
It's
Do it.
a line from Sweet Honey in the Rock song
yeah.
called Ella's Song,
Mm-hmm.
but it's the what do you call that chorus? We who believe in freedom will not rest until it comes, until freedom comes, until freedom comes. Can't rest until freedom comes. We who believe in freedom cannot rest. We who believe in freedom cannot rest until it comes. And we can't, and we won't. And we won't rest until freedom comes. And it may be a long time, it may be the rest of my days, and I hope my days are long, but I'm not gonna rest until freedom comes. And freedom in many, many ways. But one way that we can have some freedom is to not be under the Damoclean sword of these laws above our heads. So, thank you very much. I'm honored to be here. And at any point in time, whether it's now or after Dr. Andre speaks or whatever that y'all want to ask me questions, I'm more than happy to answer.
Okay. Woo! Yay.
Thank you so much, Anita. We really appreciate your coming and all the work that you do and your courage. This is an issue that progressives have to start taking seriously. It is very unfortunate in this state that our Democratic representatives and senators seem to be pushing this assisted suicide legislation. And we need to be very, very strongly telling them this is not all right with us. We are progressives. We stand against this. It is an existential threat to all of us. And Anita has explained that extremely well. I don't need to say any more. But please be in contact with your legislators. Let them know that it is not all right. We are progressives against this, and we will hold them to be accountable. I'm very grateful to Dr. Andre Sofer for joining us also today, and he'll be speaking to us. It's really comforting and important to know that there are doctors who understand just how awful medical-assisted suicide is and would be if it were enacted in Connecticut. Dr. Sofer received his undergraduate degree from Cornell University, his medical degree from the Albert Einstein College of Medicine, and his master's in public health from the Yale University School of Medicine. He completed a residency in internal medicine at Yale New Haven Hospital and worked as a general internist at the Androscoggin Valley Hospital in Berlin, New Hampshire for 4 years before returning to join the faculty at Yale. He currently practices and teaches in both inpatient and outpatient settings. His research and teaching interests include emerging infectious diseases, medical education, clinical logic, and medical ethics. With his colleague, Dr. Barry J. Wu, Dr. Sofer published a commentary in the Connecticut Mirror on June 21st of this year, in which they wrote, "What our patients and families need is, in the words of Dr. Diane Meyer, a geriatrician and palliative care specialist, a meaningful and committed human connection, not 2 grams of secobarbital at the end of life. We urge other state legislatures to follow Connecticut's lead and defeat bills to legalize assisted suicide. The practice is simply the wrong first step in a perilous direction and will make patients suspicious of our intentions at the exact time that they need us most." Thank you, Dr. Sofer.
It's fine, I'll just, yeah. No, it's good, it's good. No, it's fine, there's no sense
This
to,
one's too long.
no need to do more work. Well, thank you very much for inviting me. And thank you, Anita, for everything that you said. I agree with everything you said. So I'm not going to reiterate a lot of those points. I think that probably speaking from the medical perspective, and I won't speak for too long, we'll leave time for questions and answers, because I can give you kind of the insight of what it's like to be a physician on the other side of the table from the patient. You all have had the experience of the other side, but I think that it's useful to have that conversation. And I've been concerned ever since I came to Connecticut, and these laws they've been trying to pass this law for many, many, many years, and this is the first time that it got out of the Public Health Committee. Very concerning. So I appreciate all the work that you all are doing, and I appreciate all the pressure that people are putting on. It was interesting when I gave public testimony, as probably a lot of you did as well, before the Public Health Committee, that most of the people that were pro physician-assisted suicide have never taken care of a patient, so they don't really know what it's like to actually take care of a human being. And I have great sympathy, of course, for the stories that they've told. These are stories of people that have died in pain, or, as Anita said, with loss of dignity. And those are sad, of course, but that doesn't call for physician-assisted suicide. That calls for redoubling the efforts to understand what our patients need, to have home care when people need it, to have palliative care when they need it, to have hospice care when people need it, to let them end their lives with compassion and with dignity around their families, not to put them to death because people feel like there may be no other option because the medical system may not have all the tools and may have turned their back on them. So I was just struck by that. But I am sympathetic to the stories that people have brought up. Those are obviously important and need to be taken with great seriousness. The first time that I was ever asked by a patient to end their life, it was the first and only time. It's never happened since then. It was a gentleman that I took care of when I was an intern. So I've taken care of patients for 37 years now. So that was the first, my clinic was actually at the Veterans Hospital at the West Haven Clinic. And the gentleman was really afraid, and Anita brought this up nicely, he was afraid of pain, and he was afraid of loss of control. And he and I had a very good relationship. He had lung cancer, was what his diagnosis was. And when I explained it to him that I couldn't do that, I can't do that as a physician, I would never do that as a physician, but I would be with him till the end, and told him that we provide him pain control if he needed it, and provide him all the other things that he would have if he needed it, he never asked me again, and all went well, and he died peacefully, and that was the only time that it had ever come up. The other thing that during my career that was important for me was when I was a junior faculty member, we were all told that we needed to give a lecture, so-called medical grand rounds. And that was the time that a book came out called The Nazi Doctors. It's a book by a Yale, he was a psychiatrist who was then at John Jay College, by the name of Robert J. Lifton. So I never knew that the doctors had an involvement in Nazi Germany. This was now 25 years ago that I gave that talk. And so I studied that a little bit and studied what the involvement was. And as some of you may know, there was a large sterilization program that took place in Nazi Germany, and not just in Nazi Germany. There was a sterilization program that took place here in the United States and was allowed in many places. In Nazi Germany, the sterilization program that took place was against ethnic Germans. It wasn't against people that were targeted later on, the Jews, the gypsies, homosexuals, political prisoners, etc., that were targeted by the genocide and by Holocaust. But what happened was people were deemed that their life was not worthy of procreation. And largely it was people with disabilities, people with schizophrenia, people with alcoholism, people with a term that was called congenital feeble-mindedness, which was not really very well defined. And that same thing took place here in the United States. And Anita addressed this issue as well, is that this, like so many other things, was targeted against women. It was targeted against minorities. It was targeted against Native Americans and African Americans. They bore the brunt of it compared to others. So why is this important? It's important because it's an opportunity where the state has made a decision, the larger state or individual states in the case of the United States, about deciding who should live and who should procreate. It's very, very dangerous. I'm not telling you anything that you don't already realize, but there's a dangerous precedent now. Now, that wasn't what we're talking about now, but it's an example of where people make decisions for individuals that don't have the power to make the decisions themselves, and it's very, very dangerous. Now, in Germany, that went forward and became the euthanasia program. The euthanasia, it wasn't euthanasia at all. What happened was people that were primarily in nursing homes, people that were disabled, were brought before these so-called hereditary health courts that were made up of judges and doctors, and heard these cases. They never saw the patients. They would hear the cases and then make a decision that the person could be euthanized. And initially, people were euthanized using carbon monoxide in vans, and then they were euthanized using injections, lethal injections, and then by using gas that was the precursor to what was used later on in the concentration camps. So of course it's different from what we're talking about here. And the proponents would say there's no line that can be drawn, but it's another example of where people that don't have the right to make the decisions for themselves are having decisions made for them. So where are my concerns in terms of, as a physician, in terms of these laws that are raised, as we've talked about already, in Oregon and in other states in America, in the Netherlands? And these laws have purported safeguards, and I'll touch base on some of them kind of as we go along, that are supposed to protect people and make sure that things don't happen inappropriately. Well, the first thing to understand, I think, is that we doctors are not always accurate in terms of the prognosis. So it's very important to understand that. People think that medicine is an exact science. And of course, sometimes we have a pretty good sense of what's going to happen. The patient has a terminal disease and they're not going to get better. And patients ask me all the time, well, how long do you think they have, doc? How long do you think they're going to live? Or the patient asks me the same thing. I say, I don't really know. It really depends on so many different factors. How motivated the patient is, what they have to live for, what the family support is the family encouraging the patient? So many different factors, so you can't even say. So I think the first thing to understand, and you brought this up nicely, when it came, you're speaking about your mother who had lung disease, and she was told that she had a terminal illness and she was going to die and she went to hospice. But I've seen that example myself on many of occasions, that people go to hospice and then they leave and they come home. I had an example, I was on service at Yale New Haven Hospital just a month ago, and there's a gentleman who's in his 80s. He has end-stage kidney disease, he's on dialysis, he has cirrhosis, he has heart disease, and he's a very sick man. And he was sick in the hospital and had multiple episodes when I took care of him, when he became confused and he dropped his blood pressure and was unresponsive. And so I decided, and palliative care was involved, as you had talked about, I decided it was time to have a family meeting. And the patient was there, he was able to participate to some degree, and his daughter, who lives down in Texas, is actually a nurse practitioner, so she knows the medical system and understands, and it's a very lovely family, and we had a good discussion. And I said, look, I really don't know what's going to happen with him, but he keeps having these episodes where he becomes confused and he drops his blood pressure and he has to go to the intensive care unit and he's bleeding from his intestines, he needs blood transfusions, he needs dialysis. I don't really know where we're going to go with him. Maybe it's time to think about, not assisted suicide, of course, it's not legal, but think about maybe not being so aggressive in terms of his therapy. And so we had a good discussion about that, and we were going to have a follow-up discussion the next day. And he was participating in that. Well, wouldn't you know, the next day we have the discussion, and he's wide awake and he's alert, and the episode has none of those episodes have happened since, and this was a month ago. So, even though I thought to myself, well, maybe it's time to not be so aggressive, maybe it's time to let things take their natural course. In his case, I was wrong, and he's doing well, has done very well, and every day he's getting stronger, and hopefully will be discharged to short-term rehab. I don't know if he'll ever go home, but that's not critical. The fact of the matter is that we're not always as accurate in terms of our prognosis as we think we are. And sometimes we're not even so good at our diagnosis. So the Connecticut law says that people have to have access to a second physician, that people have to have good care, and that it has to be a qualified physician. It doesn't really define what that qualified physician is. So, you may see me and maybe I make the right diagnosis or I don't make the right diagnosis, and the prognosis under me may be good or better than somebody else, or maybe I haven't made the right diagnosis and what you needed was to see a specialist that maybe would come up with another idea for you, and your life expectancy may be vastly different. So it's very important that you're getting the appropriate medical care. Sometimes it's easy to say, well, we don't have anything else to do for you, it's the end of your life. But maybe if you saw a psychiatrist and got the appropriate medications, you would feel better, your pain would be better, your outlook on life would be better. If you saw a cardiologist, your heart condition would be treated vastly differently than if you didn't see a cardiologist. So that is critical. Who are the physicians that you're going to see? The other things that I think need to be mentioned, and Anita addressed some of this already, is these safeguards don't always work. For instance, sometimes these deaths in the Netherlands are not reported to the authorities, so you don't really know if they had terminal diseases at all. Of course, I don't agree with the law to begin with, but if you are going to have a law, you have to be able to follow that. Secondly, is if you have mandatory psychiatric consultation, lots of times in different states, in the Netherlands, those psychiatric consultations are not always obtained. So the prognosis and the patient's outlook may be vastly different if they see the appropriate people. So I think that proponents of the bill feel like they have safeguards in place, and people in the public say, oh, it's a good idea, it seems reasonable, it's got safeguards in place, it lets me have my own choice. But really, those safeguards are not always accurate, and they don't really do what people need, which is to get the appropriate medical care to make sure that they're getting the treatment that they need. The other thing that's important, and people talked about this at the Public Health Committee, is that, and Anita mentioned this as well, is people are concerned about loss of dignity. Sometimes people are worried about loss of control. People are worried about dependency on others. And sometimes people are worried about pain. But medical care is vastly different now. And as I mentioned in my testimony and to the Public Health Committee, and as I've said many times to others, is I really don't see people that are in the hospital that are dying in uncontrollable pain. There is the ability to give terminal sedation. There's the ability to have good palliative care. And that should really be the emphasis. It shouldn't be to put people to death. Because we do a lot better now than we did, say, 30 years ago when I first started practicing. So that is very important. I think the last thing that is really the most important is, and I think all of you in this room probably understand this, is that the relationship between the healthcare provider, the doctor, the nurse practitioner, PA, etc., and the patient, it's not an equal relationship. It's a hierarchical relationship. And there are patients that are willing to ask questions, and there are patients that are willing to challenge. But lots of times they don't, and they take what we say as being the end-all and be-all and the truth, which maybe it is, but we have to be very humble as physicians, as medical practitioners, to understand that we don't have all the answers. And so I feel that it is our obligation not only to walk with our patients, but also to walk with the patients' families at the end of life. I have another patient, she's 92 years old, and she has very bad dementia. She's had multiple strokes, and she has Alzheimer's disease, and she has bladder cancer that is also incurable. And I was just speaking to her daughter this week because they decided she'd had multiple admissions for urinary tract infections and confusion, and the hospitalizations are very difficult for her because, especially during COVID, when she's there by herself, the family's not allowed to be there, and she gets more agitated in the hospital, and they're very difficult. So they finally made the decision, which I think was a good one, is to bring her home on home hospice. And so she's home now. And I spoke to her daughter, who's also a patient of mine, middle of last week, and she said that she had this conversation with her mother, who's still a little bit confused, but she was very lucid one day, and she told her daughter, she said, I'm enjoying being here, and she likes to eat pineapple. I like the pineapple. She said, I'm not ready to die.
Wow.
This is what she told her daughter. And so here, on the surface of things, if you discussed her case with any number of people, you'd say a 92-year-old woman who's confused, who has Alzheimer's disease, who has terminal cancer, what's the value in her life? But that's for her to decide, right? Her and her family to decide, and she clearly said that. So I'll close there, and I just want to say that I admire everything that you all are doing, and I think it's really critical for people in the community to talk to their legislators, because those are the people that are making the decisions for us. And I'm glad to be a physician that stands with you, and I will continue to fight this because it will come up again. It has come up every other year for as long as I can remember, and there seems to be more and more support. So I think now is the time to make sure that it doesn't pass in our state like it has in so many others. So I'll stop there and just open it for comments and questions afterwards, but I'll go ahead and have a seat. But thank you again for inviting me, and thank you for all your support.